Fantastic. Okay, there you go. That's the last face I was waiting for, Hatim's. Okay, fantastic. Let's get started. I've given people 2 minutes grace. That's good enough. So welcome to the webinar series hosted by Health Education England. This is learning from the application of AI in health. So I hope you found yourself in the right place. As has just been put into the chat box, we are going to be recording this webinar and it's going to be published on the website in the next few weeks. So you can let people who couldn't make it know that they can still catch up later. As you'll find, you've been disabled in terms of your microphones and cameras. And hopefully once we get to the Q&A session, we'll get people to put their hands up and then they'll be able to come off mute and ask the panelist or myself the questions that they want to ask. And then we can take the session from there. In terms of the format of the session today, we'll have an overview from Hatim of the DART-ED program, which hopefully some of you at least will be aware of. And then each of the other three panelists, Amar, Christina, and Kavita, will introduce themselves and spend a couple of minutes talking about their work. And then the remaining half of the session, hopefully, will be a sort of panel discussion and Q&A on the things that we've raised. Fantastic. Hopefully that's okay with everyone. I'll start by introducing myself. So I'm Shuaib. I'm a consultant clinical scientist at Guy's St Thomas's, and I'm head of clinical scientific computing there, which is a team which is charged with developing people, platforms, and policy for digital health. So we essentially help translate cutting-edge digital health technologies into routine care, which is quite an exciting field to be. And as you can imagine, a lot of our work involves deploying artificial intelligence algorithms into the front line. With my other hat, I'm also the AI transformation lead for the London AI Centre, which is a large Innovate UK funded, initially it was across London, now it's expanded across the southeast, of NHS trusts, academic institutions and industry partners, where we're collaborating around developing AI prototypes along a whole range of patient pathways, primarily in secondary care, to improve patient outcomes and operational efficiency. But today we won't be talking that much about my work and more about the work of my fellow panelists. And having said that, I think we'll get started and I'll hand over to Hatim in the first instance to give us an intro of the DART-ED program. Over to you, Hatim.
Thanks, Harris. So what I'm going to try and do is just give a brief overview of what we've been doing so far, but not spend too much time, because actually who you really want to hear from is Amar, Kavita, and Christina. So from my point of view, I'm a GP in North West London, and I am a national clinical lead for Health Education England for AI and digital medical workforce. That involves looking at two areas. One is the emerging technologies around digital health, AI and robotics in education, and then what that means for education in the future. And then also being the overall lead for digital readiness for the medical profession. What I'm going to do today is just very briefly go over some of the kind of key outputs that we worked on so far. So you can go back and look at previous webinars to see kind of our approach to this problem and some of the background in terms of the policy that has driven what we're doing. But what I'm going to do is give a bit of an overview briefly about what our outputs have been so far, and then actually just highlight some educational opportunities for people that want to develop some learning in this space. So in January, we published the AI roadmap, and that was an opportunity to start to understand how many AI technologies currently exist in the NHS and what kind of taxonomies they sit within. So the majority of the technologies, you won't be surprised to hear, are diagnostics, around 34%, but then a whole host of technologies around automation and service efficiency as well. And then a growing amount of technologies around remote monitoring and P4 medicine. So P4 medicine is around participatory, preventative, personalized healthcare technologies that work at population health level. And within that, we're then able to look at what kind of workforce groups they're going to affect, how they might affect those workforce groups, and also delve deeper into a couple of those technologies to really think about what the impact might be on the way that we will work in the future. So have a read of that report, because I think it's really interesting to think about putting into your mind how things might change in the future. And then in May, we published a report which helped us to start to create a framework for how we can understand how we're going to build confidence in AI amongst healthcare workforce and what key factors are going to drive that confidence. And at national level, that's really about governance, making sure that the regulation and standards are appropriate. There's adequate evaluation and validation of these technologies, a national approach from organizations like NICE and MHRA, and clear guidelines. And then at local level, in terms of an organization, and I know Amar is going to talk a little bit about, is the strategy and the culture within an organization. Do you actually have the technical skills to be able to implement this as a technology? And then looking more closely at local level, whether the validation has occurred at that level, because we recognize that every population is different. And then finally, what does it mean as a clinician? So me as a frontline GP, how will it affect the way I work? What kind of cognitive biases do I need to be aware of when I'm working with AI? Or what do I do when it's perhaps not working as effectively as it should, and how do I then raise that? And actually, we go into this in a little bit more detail in webinar 2. So if you want to go and learn a bit about the approach and some of the findings of this piece of research in more detail rather than looking at the report, then have a look at webinar 2. So to highlight a couple of educational opportunities, we've partnered with the University of Manchester, who are developing a clinical data engineering CPD for healthcare professionals to pick and learn specific modules that will help contribute to their learning to becoming someone who's a clinician, but also will have some learning or some knowledge of skills around data engineering and data science. And at the moment, we're piloting the first module of this, and we're offering 15 funded places on this first module. And I will post the link to the chat to access how to apply to this and what to do to apply to it. Another opportunity to outline, and this is not something we're involved with, but we are aware of and support the sort of the uptake of this, is a EU-funded program, which is on explainable artificial intelligence in healthcare management. This is going to be a master's program. It's going to be delivered by University of Pavia in Italy, and one of the partners in the UK is Keele University. So whilst it being an EU-funded, it is open to applications from the UK. The program costs €2,500, but 80% of the students that graduate from the program, i.e. the top 80%, will have their thesis award paid back to them. So because of the funding that's attributed to the program. And it covers, what I think why this course is really interesting, because it covers two areas. There's the sort of the core skills around AI. So there's modules on introduction to data science and ethical AI, but also starts to also covers areas around healthcare management as well. So there's a module on transforming healthcare. There's a module on looking at AI and the workforce and the impact that it might have on the workforce. So it should be a really fascinating master's program for anyone that wants to apply. And again, I'll post details in the chat for where you can express your interest. And then someone from Keele or from one of the university partners will reach out to see if you want more information. Thank you for listening, and I will pass over to Amar.
Thanks, Hatim. Yeah, so my name's Amar. I'm a GP and digital lead and an investment and impact fund lead at Southport and Formby Primary Care Network, and a Topol fellow. So just to give people a bit of context, in the last couple of years, practices in primary care have been organising into primary care networks. And essentially, these are groups of practices that are given some additional funding, and then they provide additional services as a result of this. So in our area, we were already organised because we had quite a large federation, but the legal basis of the primary care network allowed us to organise a bit more and develop kind of the right kind of infrastructure that we needed. So a large part of my work is looking at kind of strategic and organisational level work, looking at quite open questions really, and one in particular, simply what is going on here, what's happening in our area to kind of give us an idea of how we can develop. And essentially that question's a data question. So a lot of the work is developing the requisite infrastructure that allows us to kind of utilize all that information that we have, but is largely locked up in various systems. So my work, this is an AI kind of machine learning type webinar, but my work, is machine learning, but I would say the unsung hero is just fairly simple data visualization, actually, that can be utilized with kind of more advanced tools and advanced infrastructure. So the work I'm doing is largely exploratory data analysis, looking at general kind of clinical activities, so kind of consultations that we're seeing, prescriptions, lab reports that we're having to review, documents that we're reviewing, engaging an idea about how we can apply machine learning principles like clustering, regression, and forecasting to get an idea of what is going on now and what could be going on in 5-10 years time. And then when you combine this with the other streams like financial data, staff data, patient survey, preference data, then you get a really rich picture of what we should be building. So the work at the moment relates to allowing us to kind of have extra functionality where we move past using archaic search and report systems to querying databases at source using search query language. And then we're allowed to provide that further richer analysis using things like Python or R to do that. Now that's the exciting stuff, the machine learning and the modeling, but I'd say the larger goal, it's a small part of a larger goal, which is to turn us into a data-driven product creating organization. And so the bigger areas of that and the more time-consuming areas of that are actually the foundational infrastructure. So your information and governance policies, your software, your hardware, getting that political buy-in from practices so that they really understand the value of data and can trust that group work kind of activity. So that's one element. And probably the larger element as a part of that is that team. So fundamentally, this is a people team. There is no point having a machine learning AI siloed group that does some work that's not really relevant to the rest of the organization. So we're building a digital hub, and the role of that is to get a diverse set of people, administrators, pharmacists, clinicians, and slowly allow them to transition from using Excel and your simple systems to querying databases at source, and then using your advanced analytics languages, so that over a number of years we can then develop a system where you've got grassroots innovation by people who are seeing the job and doing the job every day. So the advanced patient-facing stuff, we're not ready yet. We're not ready yet, and we don't need to be ready yet. I think this is part of a stage, a multi-year plan, but the opportunities are there, and it's just making sure that we're doing this at the right time and the right stage and creating the right culture. Thanks.
Fantastic. Thanks, Amar. Over to you, Christina.
Thank you. My name is Christina. My background is as a clinical lead physiotherapist for many years in MSK at King's. And then I did my Digital Pioneer Fellowship through Digital Health London. And then I moved across to NHS England and Improvement London region to be a clinical transformation fellow. And now I've moved over to Digital Health London to be a NHS Digital Health Navigator. So one of the innovators I'm working with called Limbic. So Limbic are an AI solution that addresses end-to-end mental health pathways. So they're implemented in 20 IAP services. They have an ORCA rating of 92%, and there's sort of end-to-end pathways. So you have Limbic Access and then Limbic Care. So I'm just going to talk about Limbic Access for the time being, and then move on to Limbic Care. So Access allows patients to self-refer to IAPs, and it uses a type of machine learning called natural language processing via a chatbot, which analyzes text input. So it picks out keywords and uses conversational AI, and benefits of that is that it engages patients in a more humanistic and caring approach and caring way. So this improves usability, and it's easier for patients to self-refer, and this is reflected by their 91% completion rate. And it also collects really important screening that would normally be done within an appointment or pre-appointment via paper, and that's the PHQ-9. So that is, for those of you who don't know, is a depression score. And that allows the chatbot to then stratify and risk flag so that the care can be adapted and tailored based on the individual needs. And in terms of like suicidal risk, a pathway can be tailored to local pathways. So asking, for example, if the patient can keep themselves safe, or following with questions around suicidal preparation or suicidal intent or likelihood, and just checking on protective factors, ways that they can keep themselves safe. So it's an AI solution that provides clinical information pre-appointment in order to support the clinicians in their clinical decision making. So the clinicians have the most relevant information and screening pre-appointment. This frees up clinical time and to allow the clinicians to add more value-based care, and therefore reduces the burden. And then in terms of Limbic Care, this uses the same engine, machine learning engine, but for treatment support tools. So whilst patients are on the waiting list, but also when they have started treatment and then post-discharge. So it helps with that elective backlog that we're hearing so much about. It helps patients to wait well while they're waiting, and it also helps with patient safety as well. So during their therapy, it can be accessed 24/7. So for example, the patient can log in and say, I'm feeling anxious, and it will reply saying, your therapist has recommended some breathing exercises. Shall we do this together? Okay, let's go. Now, this sounds very simple, but we know that when anxiety and depression can inhibit problem-solving abilities, so it can be really beneficial from that point of view. So it can be accessed at the weekends, 24/7. And then post-discharge, it allows access for patients to sort of help prevent that relapse. So Limbic is never going to sort of replace clinicians at the moment, but it supports clinicians. And we know that AI is not ready to replace humans, as it lacks the sort of human values that are really important to patients and individuals, such as empathy and that gut instinct. However, the benefits, in terms of user benefits, it can be accessed 24 hours a day, 7 days a week. And we know humans need to sleep, so we all need to sleep. The chatbot doesn't need to sleep. And the feedback from patients is that they feel less judged speaking with a chatbot. and it's less burdensome than speaking to a human, which could be really beneficial and makes it much easier for those with social anxiety. And in terms of clinicians and the benefits of clinicians, it reduces, by supporting the clinicians, it reduces that workforce burden. So we know that workforce burden is a huge challenge to the NHS generally. And clinicians like having information prior to their appointments. It allows preparation, including seeking support for those more complex patients. It just reflecting on my time at King's, we used to do pre-appointment screening, including the PHQ-9, including the Start Back, which is a MSK stratification tool. And it really does free up time during the appointment so that you can spend more time with the patient in their appointment time, actually adding more value. So, you know, we're very aware of the sort of pros and the sort of the benefits and the limitations to AI, but overall, this isn't trying to replace the clinician, but more about supporting the clinician. I'm happy to take any questions after. So I'll pass on to Kavita.
Thanks, Christina. Hi, everyone. My name is Kavita. So a little bit about my background. I'm actually a cardiology registrar in Northwest London with a subspecialty interest in cardiac imaging. I'm currently in the second year of my PhD at Imperial College London, where I'm developing a novel AI-based clinical decision support system, which enhances the acquisition of cardiac MRI. I have a particular interest in valvular heart disease, and therefore I'm focusing a lot of my research in training neural networks to accurately identify valvular abnormalities in different cardiac views. I've also got a bit of experience in using semi-supervised natural language processing, or some of you might recognize this as NLP, algorithms to accurately categorize diagnosis, and that was specifically in cardiac MRI from radiology reports. So, you know, we could utilize this for very quickly screening through lots of radiology reports and pulling out scans that we would need for a specific experiment. And part of my PhD, I work very, very closely with a very diverse group of people, including engineers, medical physicists, other clinicians, to create these algorithms. I also lead on the AI lab at Imperial, where we conduct sort of fortnightly forums to promote this sort of collaborative working, really, where fellows like myself are able to share our current findings, challenges in some of the development of these algorithms, or maybe the implementation work that we're carrying out. And we try and work through some of these challenges together through this forum. And I guess what I've learned mostly through my PhD is the experience of data procurement, and this is both locally and nationally, and both of these types of procurement, so whether you're trying to get data locally from your NHS trust or nationally, say from the biobank, they both have very different challenges in trying to navigate through each of that. Applying for ethical approval, and then sort of utilizing medical images for AI, and specifically for that data curation part, which is sometimes the most important and most difficult part to get right before you start training these AI models. So that's part of my week. So half of my week is spent on my PhD, and the other half of my week is spent as a clinical AI fellow at GSTT. I'm one of 11 clinical AI fellows on this first cohort of its kind that Harris obviously initiated. And one of my main roles in the Clinical AI Fellowship is currently supporting the development and evaluation of a CE-marked AI tool. And CE-marked, for those of you who don't know, just means that it has regulatory approval. And the software that we're going to be working with, or the company that we're going to be working with, is Cure AI. The specific product is QER. What QER is, it's an algorithm that can detect up to 11 critical abnormalities from non-contrast head CTs. And what we hope is that through this product, we'd be able to prioritize the most critical scans for reporting by radiologists. Therefore, patients coming in with a stroke or major trauma with brain injuries will quickly get treatment that they need through that prioritization. And the software we hope will be deployed within the emergency department and radiology workflows. As with any other study, AI or non-AI, there's always the process of developing the actual study protocol. And we're at that phase at the moment where we're designing the prospective study, which will eventually be conducted across 5 different NHS sites. And these are major trauma centres, stroke centres, and a DGH. I'm also supporting the ethics application in this, and also collaborating with our industry stakeholders, particularly in terms of managing their expectations. And eventually I'll be leading on the academic outputs from this project. And I think this is often the rate limiting step, this initial thing where you have to really just get going, design the study, get all the sites together, get all the PIs together, and see what everyone's expectations are of all of this before the study can actually even get going. One of my main objectives, I suppose, by the end of this is to create a body of evidence to build that trust and confidence of the healthcare workforce in this specific AI system, which can then allow it to be carefully scaled up for use across the NHS sites. And what I'd like to take away eventually from the fellowship is to help me better understand all of these challenges and the various different phases or the life cycles of implementation of AI tools, which would then give me a transferable skill set for deploying similar projects into hospitals in the NHS. Thank you.
Fantastic. Thank you, Kavita. Thank you, Amar and Christina as well. Fascinating introduction to your work. And I have to admit, I didn't have any input into the construction of this panel, but I'm so glad we have such a diverse, in just 3 people, we basically cover everything, which should hopefully make the Q&A quite interesting. We've got secondary care, primary care, mental health, different clinical backgrounds as well. We had people send in questions prior to the event, and so I'm going to use some of them as a launching pad into what I want to ask, but I'd also be keen for people to put their hands up if they've got questions based on what they've heard so far. One of the things I want to start with, and I'll address this to everyone, is a few of you mentioned the importance and the challenges around data. And there was a question by Lee Whitaker that was sent in about what, if any, are the major risks or drawbacks about AI in health. One of the major challenges is around the quality of our data infrastructure. And particularly around the development of AI, you require often large data sets across many different geographies, and that means crossing institutional boundaries. And I'd be very interested to hear about the challenges you've faced and ways that you've overcome that. Amar, you talked about how your new legal basis as a PCN enabled some activities. Did that make it easier to get access to run SQL queries on larger cohorts of patients, or was there still, 80% of the work still outstanding to do? So to you, Amar, first.
Yeah. I mean, the truth is everyone's terrified about data, really, aren't they? Data sharing. And that's by far been one of the, I'd love to be focusing all my time into building models and doing that kind of analysis. But actually, one of the bigger areas which has caused the most delays is that information governance policy and ensuring that everyone is aware of what's going on and the right kind of stakeholder buy-in. What's complicated more is the sort of rollout of the national data opt-out, which made it even more difficult, where you had people that were opting out, not really knowing why they were opting out, practices not knowing what was involved in that and what that actually meant. And so our way of dealing with that is to be very basic. I mean, you want to remember, I mean, general practice, the baseline for, I suppose, digital maturity and data infrastructure maturity is very low. So we don't even really need to be thinking too much about AI right now. We just need to do the foundational blocks that we can then build on. So one of the things in terms of moving forward was just, existing IT providers but have the ability to provide new ways of searching. Great, that's straight away, that's a tick box to that pathway towards being able to build more complex kind of analyses. And then just using what we can that involves things like implied consent anyway. So clinical audit is classified under direct patient care, and one of our things that we can do in practice anyway. So making our use of these technologies related to things that are already part of our day-to-day work before going on to those higher level areas. So I think what's helped with our organisation is that the sharing that's going on. Because I mentioned we're already organised by a federation for the last several years, and then that's turned into more of a PCN as well. We already had data sharing things in place where we were providing direct care, so it made it a lot easier for us to do that. But I'd say the biggest challenge is making sure that practices are organising and having that ability to have a plan for direct care of patients, and then allowing that kind of direct kind of clinical audit kind of pathway. That makes it much easier.
Fantastic. No, really interesting. And turning to you, Christina, particularly with the Limbic app, where you have an end-to-end pathway management where you're potentially jumping from organizations or from different services. You mentioned that you're able to refer to a number of IAP services. Does that present challenges? How has that been in terms of implementing Olympic or clinicians being able to use Olympic to its fullest extent? How has data flown across organizations, or is it easier because a lot of the data is held or controlled by Olympic themselves?
Well, I believe that the data is held by Limbic itself, so that does make it easier, and then the clinician can input into the app so that it can help with that limbic care when a patient is having sort of a more of a slightly, having a bad day, more anxious or depressed, and then can sort of pull that information from the clinical side to help support the patient. I'd say one of the sort of challenges really is with the ICB and knowing where the funding flows are. I'd say that's probably one of the sort of challenges for innovators at the moment. So rather than it being sort of organisational, just the funding flows from an ICB level. I don't know how everyone else feels about that, but that's kind of the main challenge from innovators that I've been working with.
Okay, interesting. So is that funding for the innovation itself or for the underlying infrastructure to enable it?
The underlying infrastructure, where ICBs are relatively new sort of set up, and it's sort of having those structures around and the framework for funding flows is not that obvious, and there's quite a bit of uncertainty around that. So I feel that's quite a big barrier for innovation at the moment.
Yeah, no, certainly. Kavita, just to bring into conversation, I think you have an interesting perspective in that your week is split between being a developer and an evaluator, or a deployer and evaluator. And what are the different challenges, right? I mean, I'm involved in very similar activity, and I know that it's relatively easier to curate static data sets, right? Obviously, there's a lot of blood, sweat, and tears that goes into it, but it's static, and you have a big cohort of data that you throw into your machine learning algorithm. At deploy time, when you want to evaluate it, say in a prospective trial, now you need the data to come in the same structure and format, but you need it to come live. So in your experience, what's been the challenges? Has that gap been too big to overcome, or has it worked well in some pathways?
So completely, as you say, Harris, it's sort of then getting the outputs to the patient, which is ultimately why we're all doing what we do. It's a little bit different on my end because I work a lot with industry in terms of industry, in a sense that the algorithms that I'm developing are for MRI scanners. Who owns the MRI scanner? Siemens, GE, for example. So to get these algorithms onto the magnets, essentially you have to be able to converse with those teams and actually convince and eventually they are your stakeholders, get their buy-in to, have them be happy to have your algorithm on their magnet. And that has to be robustly tested before they would allow you to integrate your algorithm onto such a big, already multi-diverse software. So it's not easy. We have at the moment incorporated some of our early work where we're able to get in on the fly outputs for, say, cardiac volumes, mass calculations, etc. But that hasn't come easy, and you have to obviously pre-label everything for research purposes only. And the other thing I think with that is just, being able to provide evidence that you have tested and validated your algorithms. So, trying to train and test just on one data set from one hospital on one scanner type, it may not be applicable to all other scanner types or, different softwares. So, you have to really get data where you can show that what you've developed is actually transferable to other clinical data sets. And that's one way which we are trying to get around some of this. So some of my early work's been developed on noisy clinical data from Imperial, but we're now trying to validate some of those algorithms on the UK Biobank data set to get a bit more leverage, essentially, and validation.
Fantastic. No, really interesting. I think what's clear across all of those domains is, I think we've come a long way in the past, so say 5 years, in the amount of attention that frontline clinicians like yourselves, as well as corporate and support services like IT, have put into data infrastructure. I think everybody knows that without solving that, nothing else gets solved. One of the things that the London AI Centre has been working on is exactly those kinds of problems. I won't talk about it too much right now, but we have two sort of flagship platforms. One is the federated learning platform, which essentially allows us to develop algorithms without moving the data at all, which solves some of the privacy and IG risks around extracting data from data controllers. You essentially move the algorithm to the data and then aggregate the learning. And then the other side, we have the AI deployment engine, which solves some of the interoperability challenges, Kavita, that you talked about, where essentially you have a single to which you can deploy algorithms and which can communicate with the rest of the hospital in an interoperable way. I'll put a link in the chat for those that wanted to read up more about it. There aren't any more questions that come in, so I'm just going to carry on talking about stuff that I like to talk about. You guys, in all of your work, have, I mean, the industry collaboration is pretty crucial to this all, right? And also, Kavita, there's a pretty strong academic component, particularly when it comes to evidence generation, right? And figuring out what should we pay for and what works and what doesn't work. And it reminds me a bit, less of the academic component, but when we were sort of digitalizing healthcare sort of 20 years ago, and we had sort of the first PACS contracts coming out, and we had sort of the National Program for IT, and then 10 years later, when those contracts were coming to an end, we learned a lot of painful lessons about how we didn't quite set up those relationships for success. It was very difficult for a lot of us to move to our new solutions or to our new providers. In your recent experience working with industry and with academia, what are some of the sort of key takeaways that you've come away with that would ensure the NHS partner gets the most out of that relationship? Or does the relationship need to fundamentally change because now we're a bit wiser? Kavita, do you want to kick off with that?
Yeah, so I think in terms of, you've got to manage expectations in terms of what your NHS partner wants to gain out of it and what industry wants to get out of it. And I think in terms of your NHS partner, what they want is essentially, we've got a limited amount of resources. Our resources aren't growing exponentially, but demand is growing exponentially. And so how can these AI solutions be of use to mitigate some of those issues? And it has to be a cost-benefit relationship, I think, eventually. And I don't know if it has been proven yet that all of these AI solutions actually are going to be beneficial from a cost point of view. Some people might argue and say, well, just hire more healthcare staff for the price that you're paying for these AI solutions. So I think what we're doing at the moment in terms of collecting this body of evidence, say just from my CURE project, is actually then conducting a health economics evaluation to see whether solutions like these do actually benefit NHS partners and actually make a difference to patients eventually, and that they are soluble for mitigating some of the issues that we foresee and are happening right now, especially in the post-COVID pandemic era, where there's a huge backlog of cases, demand for healthcare is higher than ever. So those are the things that I think we need to work on between healthcare partners and industry, and trying to find that ground where we're working towards a goal that together, basically.
Fantastic. Christina, I think you have a really interesting perspective, particularly, and you don't need to focus on Limbic, but with your role as an NHS navigator with Digital Health London. From your perspective, the HSN's role is to increase adoption of innovation, and you're usually very good at connecting innovators to trust and the like. What could we do better from the NHS perspective to help innovators and to get the most out of it?
I think the biggest barrier is around implementation, and we know that workforce, what current workforce are kind of on their knees at the moment. There's a huge workforce crisis. Taking on a new innovation is just an extra thing for our clinicians and our workforce, our service managers to do when they're already inundated with an elective backlog. So trying to get that initial implementation is a huge barrier for the workforce generally. I mean, I think the issue is it's not just the fact that the workforce is burnt out, it's the fact that, positions are not being filled. And so even if we recruited more clinicians, if there was money to do so, we're going to really struggle to recruit clinicians and to recruit workforce. So AI therefore can support the workforce when they're already depleted. You know, I know of jobs that have been re-advertised because they're just not being filled, whereas maybe 5-10 years ago they were filled very, very quickly, and you'd maybe have 50 people applying for the same job. That's not really the case anymore. So that's the sort of first thing, is around implementation when the workforce are on their knees. And what I encourage innovators to do is really help with that implementation process, to sort of almost provide project management support to the NHS Trust or to the NHS organisation to help with that implementation process, to offload the burden on clinicians just for that initial phase until it becomes almost business as usual, and then there can be a transition period across. So that would be sort of my thoughts on it.
Fantastic. And that leads nicely to what I wanted to ask Amar on this topic, and it also relates to Kavita's AI lab and the forum that she has. Amar, you talked about a sort of a hub that you're trying to build and a sort of an in-house team. How far can we take that? In your locality as a PCN, or just generally as an NHS, where we are sort of in-housing some of the deeper technical expertise when it comes to AI? Just conscious of time, but briefly your thoughts on that would be interesting, on how far we can go with that.
Yeah, I mean, there's an interview with Satya Nadella, who's Microsoft's CEO, and they ask him what is the real innovation that they see with AI, and his response was he's most excited about the grassroots uptake, the idea that someone who's doing a job every day can have a packaged bit of software or code that is already built for them, that they can then apply in a day-to-day thing that can help. And that's essentially, where the real innovation comes. It comes from the kind of, the ground up. And so it's kind of enabling people to do that. Now, realistically, we can't expect everyone in an organization to become a specialist in whatever data science or AI. That's just not going to happen. But you can certainly target people that are interested in it and have some sort of local structure where they can then engage with the wider group. So I think it's about providing opportunities locally to do that, and then providing support where they can take it to the next stage. So we have like local innovation agencies or innovation funding where we can take that route. I suppose the other element is that, I suppose it's Kavita's point about expectations. I mean, an AI product is essentially a startup, really, or it's being used as a similar way to a startup company. I mean, how many startup companies are still alive in 5 years' time or 10 years' time? And I think that's the reality of it. So it's being aware that, when you're investing in this area, be realistic about what you're trying to achieve, and infrastructure and governance and ethics and all of that kind of thing can then grow other elements, rather than gambling essentially on a few topics that are questionable whether they'll be around in 5 years.
Fantastic, Emma. No, very, very pertinent point at the end. No, I completely agree. That brings us to 1 minute to go. And so I'll take the opportunity to wrap up then. Thank you so much, the panelists, for sharing their background and the work that they're doing, all very much at the coalface and really grounded in the realities of delivering healthcare. So hopefully the audience appreciated that. And of course, thank you to the audience for listening in and for participating with the questions beforehand. There's been a bit of chatter in the chat, and that's mostly about connecting with some of our panelists. So hopefully we can follow through with that at the end. From my perspective, I just want to say, thank you to the organisers as well. There will be a recording, like I said at the top, that's going to be made available on the Dart Ed web pages. And finally, you can follow Dart Ed on Twitter, and hopefully the handle will be in the chat for you to follow, and then you can stay up to date for any future webinars. And that's everything from me, and hope everybody enjoys the heat. Take care.
Thanks. Bye.
Bye. Bye.
Bye.